what is great about it is when I was on all those other medications, I was completely dizzy, confused all the time. Whereas now, I'm actually, everybody who sees me now says I look much younger. I'm completely, I think I'm all right.
That's Lucy Hanson. She's 92, and frankly, she's kind of amazing. She went through a long and strange journey from being diagnosed with dementia and many other conditions and being on an insane panoply of medicines. And you hear her now. This is after the fact. And I remind you, she's 92 in this audio. I'm Seth Lorenzi.
And I'm Jeremy Cosson.
Welcome to Zana Medical's Health Lab. Health Lab is an episodic series podcast. Each series focuses on a specific medical condition through the lens of clinical cannabis. This series is on insomnia. Each episode examines the issue further through specific populations, and this episode, episode 4, focuses on seniors.
So Lucy has a really interesting story, and I think it is pretty typical of this population. What we know is that seniors are actually the fastest growing population in terms of actually using medical cannabis, but they've had the longest sort of held stigmatization towards it as well. Things are changing, and I think you'll find Lucy's story really interesting.
Yeah, here's Lucy again.
No. If I had known, I would have said no, because what you didn't hear is I was so much anti-drug, having been a young woman and a little bit older during the 60s, seeing what the drug, those kids were, really turned me completely down on any kind of drug. So no. And the only way I found out is when I was brought my pill one day, and the young woman who brought it said, "Well, Lucy, here's your marijuana." And I said, no. And she said, yes. And so I told Tanya later, I said, "You didn't tell me it was marijuana." And she said, "Mom, if I had told you."
Well, I just want to point out here that during this, Lucy's daughter, Tanya, was not surreptitiously dosing her. I mean, Tanya was acting as her medical caretaker, and she was under advisement by a clinician. This was not a random experiment. I just feel the need to say that.
Exactly. I mean, there was multiple care people. It was the executive director.
Right.
And her nurse. And
Lucy was suffering cognitive impairment because Lucy had been diagnosed with dementia as a result of the meds she was on, not of anything native to her.
Yeah, they thought it was natural, but it was actually drug-induced from all the different morphine that she was on, or sleeping medications, all these other things.
Yeah. So, okay, I feel like this illustrates a really top-level point. Cannabis is potentially so helpful to seniors for many, many conditions, insomnia being just one of them. But why are there so many barriers to its use in this population? Part of this, as you point out, is cultural and historical. There's a stigmatization of cannabis.
No, I find it, honestly, it's sort of perplexing because it's probably the population that could really benefit the most.
Oh, I think everyone agrees on that.
Because they're on, so many different medications oftentimes, and some of these medications could be replaced by cannabis. And in fact, there was a report that came out that said actually in medical marijuana states, Medicare had saved $160 billion. And, we're talking about quality of life, improving quality of life. That's right,
exactly,
most important.
Especially in the end stages of life.
Exactly. But, in certain conditions that they have, it's still experimental, and then their doctors aren't necessarily, they're not the front line in terms of
in terms of prescribing.
In terms of prescribing it, they're more than open to prescribing morphine or hardcore sleep medications. But
that actually points to something that we talk about a lot at Zana, which is the clinical gap. Many patients don't understand the potential uses of clinical cannabis. Many doctors don't understand the uses of clinical cannabis. And that's a theme that rises again and again. In fact, Lucy, the subject of much of the story, she ran into the same thing. She ran into doctors who were unwilling to prescribe cannabis.
And again, I can empathize with physicians. Like, are you going to send, if they don't have an attending nurse like Lucy has, are you just going to prescribe or recommend cannabis? Or are they just going to go down to a dispensary, and what are they going to get? What are they going to come back with? We don't know.
The logistics are not crystal clear yet.
Right, exactly.
Yeah. Okay, so we've established in earlier episodes that cannabis can successfully treat insomnia. But how are insomnia, and sleep for that matter, different for seniors than they are for younger people?
So our sleep cycles change. They evolve as we get older. So babies, they have almost all REM sleep. They're in that learning process, we think.
Right.
And as you get older people's sleep cycles change. Plus, they're also usually on a lot of different medications, which also influence their sleep.
Well, I'm thinking medications, and I'm also thinking conditions too. I think
exactly.
Chronic pain is a huge impact on sleep.
Right. And so that population as well suffers from insomnia at much higher rates than the whole rest. And society does suffer from insomnia at a pretty high rate, but among seniors, it's even higher.
It's really high. Yeah. Earlier in the series, we talked about cannabis's relative safety. I'm thinking of moms talking about discussing it with their kids and feeling okay using it around family. But that said, when we're talking about seniors, there are special challenges, I think, to even initiating those conversations. How does one talk with their parents or with their grandparents or with their caregivers or physicians, for that matter, about clinical cannabis? Does this bring up larger issues of anxiety around caretaking for our ailing parents? I mean, there's a lot of meaty stuff in here.
Yeah, no, I think that's a great question. And actually, that was one of the questions that I asked Lucy, because she was obviously sort of, culturally resistant to considering cannabis. And she said, had she been asked, if she was lucid enough to be able to be asked, she probably would have said no.
Right.
And so I said, absolutely. Well, how would you have overcome that? And I think she said something along the lines of maybe introducing it slowly, kind of like the drip method, but providing sort of the data and the evidence and the research and solid articles and that sort of thing, but just taking a gentle approach to it.
You know what word is bubbling up in my mind?
What's that?
Process.
Yeah, you got it.
Yeah.
Well, actually, so there's a process, that's like a pre-process. Yeah. There's a process before you even get to the process of figuring out the actual treatment side of it. But there's a pre-process.
Well, just one more thing I want to bring up in this introductory segment. What about the mechanics of taking clinical cannabis? In general, remember, this population has the greatest discomfort around cannabis. So for some, like Lucy, inhalation, or the quote-unquote standard administration, unquote, wasn't the best approach.
No, and
for many reasons.
Yeah, and that many people that are still thinking in terms of smoking, but that's not the way that most people are actually. Yeah, and especially in the senior population, they're not popping out a bong and smoking out of a bong. There's we're talking clinical use, clinical administration. So
right.
It could be a tincture, it could be a capsules, it could be a variety of different forms of administration. Well, smoking would be the least desirable.
Yeah. Well, I also think of a phrase that you brought up the other day, which was, this is not your parents' weed, or in this case, your grandparents' weed. And that usually talks to potency. But in this case, we're also talking about administration and usage overall. I mean, it's very, very different than our parents' or grandparents' generations experienced it.
Right. Well, and there's a lot of sort of misconceptions around that, and I'm not going to go into all of those. But a lot of the sort of cannabis that was around back in the 80s or 70s, I mean, this was stuff that was made, that was imported from Mexico or Colombia or other places, and it didn't have nutrients or these other different cannabinoids and stuff like that. It was quote unquote dirt weed. So it had lower potency, and it had just a bunch of crap in it. Right. So the potency may be higher today, but it's also richer in other cannabinoids and other terpenes, and we know a lot more about these important other parts of the plant.
Well, okay, that brings to mind another concept, something that we at Zana call the optimal dose. Basically, the lowest dosage that has the efficacy that we're looking for.
Right, exactly. I mean, when we're talking about a therapeutic dose, we're looking at the lowest dose that elicits a therapeutic benefit.
Right. I want to play a clip from Greg Fry, whom I think you know personally.
Right, exactly. So Greg's also a writer. He's the executive online editor, actually, for a great website, Green Flower Media. And so we had a conversation on, because he wrote an article about how to talk to seniors about cannabis.
Mm-hmm. And I have to apologize. I think he was in Greece when you were speaking to him. The audio is not the best.
Are you talking about the musical? No. Oh, right.
Yeah,
no. He was actually
he was weird
he was
singing in the background.
He was in Athens, and I think they had some sort of currency deflation or something like that. And they just there were some internet connectivity issues, but
okay. Okay.
The information's good nonetheless.
Yeah.
Yeah, and with anybody, it always takes a little trial and error to find the best dosages. And you mentioned the therapeutic dose. That's a great point, because with this medicine, we're not always shooting for psychoactivity. That it has its own benefits, but there's what we call the therapeutic window. And the low end of that doesn't really involve psychoactivity for a lot of people. And if you get into the higher end of that, when you start to exceed your threshold a little bit, you start to feel more psychoactive effects. This is a different experience with the medication.
That's so interesting, because I feel like for most of the population, the idea of accessing cannabis is for the psychoactivity. But he points out that for seniors and many others, frankly,
myself included,
right, who are looking for an entirely different effect and not necessarily a quote unquote experience.
Right. Well, I mean, any drug that actually acts on the central nervous system is considered psychoactive. So that includes SSRIs, antidepressants, all those different drugs.
Right.
But I mean, you hit the nail on the head. Hit the head.
That's my line.
That's your line.
Yeah.
Right. But many people, I mean, we want the therapeutic effect, but we don't want necessarily the psychotropic, psychoactive effects.
Yeah. And again, that's especially important with seniors. Okay. That's a great start. Thanks, Jeremy.
Thanks, Seth.
Yes, even as a child, I did not sleep well. So, I mean, this is not new.
That is, of course, Lucy, our poster child for this particular episode. And as she points out, she's been suffering insomnia for 80 years at this point.
Since she was a child.
Since she was a child in France. But first, she has other fish to fry. Let's hear from her daughter, Tanya.
Like I said, I honestly prayed that my mother would die, because she was in such bad shape. It was miserable for her because she would get confused and frightened and frustrated because she couldn't speak properly and she couldn't walk properly.
That is hard to hear. That is Tanya, Lucy's daughter, talking about trying to find care for her mom. Her mom is slipping quickly. It seems like a growing cocktail of meds is the only thing.
And even Lucy said she was just she had resigned to counting down the days until she passed, right? She didn't have any excitement over life, period.
Right. Okay, let's follow a little bit further.
When she was 90 years old, her health was deteriorating rapidly. And we had her evaluated by Kaiser. And by the neurology department, they felt that she had dementia, and they had a special facility or a special department that looked over every aspect of her health, including her medications.
Right. Before I say much further, let's hear about the experience from Lucy's own perspective.
I had no idea where I was. I kept telling Tanya when she came over that I wanted to go home. And she was saying, well, you are home. I said, no, I'm not home. I want to go home. And I had to get out of bed and go outside to see if my name was on the door.
Yeah, I mean, it's pretty shocking hearing such a vibrant woman talk about being in such a fog, and as it turns out, a medically induced fog. But let's push on. It gets worse.
In July, I got a call from my mom's assisted care facility on a Sunday evening, and I thought, oh, great. They are going to tell me they can't keep her there anymore because her needs are too great.
Right. Things are looking pretty dire at this moment. Lucy's on a ton of meds. She's slipping fast. And now seems like a perfect moment for a cliffhanger. Let's switch gears and talk with a few other people about how they introduced their parents to cannabis. Let's start with the subtle approach.
So 20 minutes goes by and I said, so what do you think, Mom? I mean, she says, well, I mean, I can tell you this, I'm up walking around and I probably wouldn't be. I guess something's happening. And so she was, really surprised by it. And so, the weekend went on and she said, hey, can I keep that? I said, sure. I said, of course. That's why I brought it. I said, well, I can't mail anymore to you. So the next time I see you, I'm going to have to, see you to give it to you. Because, unfortunately, I can't mail it to you. And she says, well, why can't you mail it? I said, well, Mom, because it would be a federal offense. I said, it's made from cannabis. That's the herb that's used in it.
That's Rhonda, by the way. She's a designer who lives
and you're getting the guidance, of people in the dispensaries, and some of them are extremely knowledgeable, and others are not. There's no standardization there, so it can be
more direct. Yeah.
We spiked their martinis with
cannabis.
So
that's a lot of what I try to do is just really provide them with that support.
And we said, see, you like it.
That ongoing support. The more they work with me, the more success they have.
My mother and father-in-law were very open to it. They had used it in the 60s and early 70s. So
it's not my favorite.
They're all retired. It just wasn't a big deal. They just wanted to try it. And now it's been part of their life for several years, using cannabis for different ailments or just pleasure too. I mean,
well, okay. All kidding aside, this brings up a really valid point, which we kind of touched on earlier. For seniors, taking clinical cannabis is a different experience than for younger populations for a number of reasons. And we've already seen a couple of cases in which folks more or less snuck cannabis.
And we turn to Dr. Nick Jacobus. But he's a Harvard-educated PhD in neuroscience, and he's also the senior science advisor for Leafly.
Taking clinical cannabis.
Oh, by the way,
right, and you brought up the different routes of administration or intake methods, right?
Right, absolutely. Which is again, we grew up thinking of cannabis as something that you smoked.
Right.
Right. I mean, still, I feel like the iconography of cannabis is someone smoking a joint or a bowl, and that's less and less how it actually occurs.
Right, and especially with this population. I mean, there these tinctures and capsules and because you just smoking is kind of a crude form.
Right,
and even vaporization, they're not doing vaporization as much.
Right. Let's hear what Dr. Jordan Tischler has to say on the subject. And when we join him, he's talking about products that he selects for specific populations.
And those criteria were portability, ease of use, because we also have to remember that, it's not just millennials who are using this. It's grandma, who's 80-something and has difficulty using her hands and her eyesight isn't very good and those sorts of things.
And so there's the mechanics of taking cannabis. And then there's also the entire question of dosing. How much you take, when you take it, why do you take it? I mean, again, you know what word I'm going to say?
Process.
Okay, let's get back to Lucy. When we left off with her, things were not looking good. Her daughter, Tanya, was worried that she was going to be evicted from assisted care. And then she gets a surprising phone call.
And actually, I was very pleasantly surprised. The director of the facility told me that she had been watching my mom and that she was concerned she was suffering from aphasia. And the director had gone and looked at her prescriptions and felt that mom was being way overprescribed for pain medications.
Right. So this speaks to duality, if you will. We've talked about institutions like the VA being more than willing to prescribe a lot of opiates and other kind of heavy pharma for people who are suffering from insomnia and other conditions. But patients want those drugs as well. There's a demand for them. And as Tanya points out, her mom was one of those people. She was not being force-fed these drugs.
I have to say in the doctor's defense that whenever we would go to an appointment, mom was always pleading for pain medications. She was also having problems sleeping. And so she basically would just sit there until the doctor wrote her a new prescription.
No, and this raises an important point because, we tend to vilify maybe the medical establishment or vilify the VA, but there's a reciprocity here because there's patient demand and there's also willing participants in terms of providing them that medication. So it's not just a one-way street, and nor is it endemic just to one institution. It's pretty pandemic, actually, across our medical system.
Yeah, well, people want relief.
Right? Well, people, yeah. I mean, surprisingly enough, people that are suffering want relief.
Yeah, I mean, I think it's something that Dr. Babson said. She was explaining why pills come first, basically. Pills come first in the line of treatment. What's that called? First, it's not first response.
First line treatment.
First line treatment. Pills work quickly. You take a pill and something happens.
Right. And the most beneficial treatments are often the ones that take the most commitment and the most work.
Right. They have to be integrated into your life, unless you're living multiple lives or multiple personalities.
I think that's just you.
Thank you for that. Okay. To sum this segment up, we followed Lucy and her daughter Tanya's journey. We've learned how some other folks introduced, or in one case, reintroduced their parents to cannabis. There's a lot of ways that seniors interact with cannabis, and there's a lot of ways that seniors interact with insomnia. In this next segment, we'll introduce some clinician voices and get some perspective on these issues and continue learning why these things are not the same for all people. Seniors experience insomnia and sleep differently than we do, and they interact with cannabis differently than younger folks do. So let's leave it at that. Thanks, Jeremy.
Thank you, Seth.
Welcome to the exciting segment 3.
We are at segment 3.
Okay, it's time to hear from some clinicians and get more of a backdrop on what seniors are coping with when we talk about insomnia and when we talk about cannabis. And I actually want to peel even further back and talk about sleep and how it changes during the lifetime.
And Nick has some great points.
That's Dr. Nick Jikomes. He's a Harvard-educated PhD in neuroscience, and he's also the senior science advisor for Leafly.
Basically, this is one area where the everyday experience of all people matches basically the science. When you get older, you sleep less, and your sleep is more fragmented. Your sleep is just not as good as it was before. So it's very, very, very common for older people to report sleeping less, going to bed earlier and waking up much earlier, and also to be more fragmented in their sleep, to wake up one or two or several times during the night. That's extremely common.
Yeah, and just in my own life experience, it's funny, I didn't even realize it until this moment, but that totally jibes with my experience too, of my parents and grandparents complaining about poor sleep. And as a child thinking, well, what's the big deal? I don't even want to sleep. Why are you complaining about it?
Yeah, I mean, it is interesting, right? Because as you get older, but they fall asleep at much, much earlier, and we'll wake up much, much earlier in the day.
Right. Let's hear as he goes into a little more detail.
There's a couple things at play here. One, the total amount of sleep per day decreases as we age. And two, sleep architecture changes as we age. So we talked about this at the beginning. The ratio of non-REM to REM sleep changes as we age. When we're infants and we're very young, we have quite a bit more REM sleep each night than we do when we're older. So the amount of REM sleep we have every night we go to sleep is slowly but surely decreasing as we get older.
Okay, but what does it have to do with insomnia, if anything? Do you know?
Well, you bring up an interesting point because trying to avoid going into too much scientific detail because I'm afraid it could be a good thing. I may put you to sleep. your insomnia.
Thanks. Well put.
No, it's just in terms of sleep architecture, right? It changes dramatically over the years. We go through, when we're a baby, right? That's when we think, there's a lot of REM sleep. And that's kind of like, because babies are learning so much.
It's the absorption phase of our lives.
Right. And then as people get older, well, we need to learn less and we need to have sort of a restorative phase more, right? So it's more about, but it's fragmented. So it's not actually, interestingly, I mean, if I was going to look at it from an evolutionary perspective, it doesn't really make a lot of sense. Like, why is it so fragmented at that age? And maybe that is the sort of answer to
is that because
life extension.
Well, I was going to say, is that because we live longer?
It could be, but if we could figure out how for it to be less fragmented, then we could probably live to 150.
Do you really think so?
I don't know. I mean, it sounds good.
Oh. Thank you. Okay, so back to insomnia. What does that mean for seniors and insomnia if their sleep is changing? Eloise, who we heard from in an earlier episode, had a really great answer, several answers for this. Let's listen.
In the older population, they may have lost a spouse. They may be dealing with, multiple chronic health conditions. They may be, dealing with facing their own mortality. Their friends are dying. Maybe they're drinking a lot of alcohol. That becomes, a lot for a lot of them. They use alcohol as a medicine to treat their pain and anxiety.
Yeah, I chose that clip for a reason. I think harkening back to alcohol and its historical use as a medicine.
And it's not a very good medicine.
No, as it turns out, it's not. It's great for sterilizing things. And
well, right. I mean, we know that, alcohol is a neurotoxin, and which means it does actually hurt your brain cells. And cannabis actually, or not cannabis per se, but the cannabinoids are actually neuroprotective. So,
oh, wow. That's
and they promote neurogenesis, so they actually regenerate neurons.
Wow. Oh, that's fascinating. Well, actually, that's also a great lead in to Dr. Nick's next comment. He's talking about insomnia in seniors specifically when we break in here. Hang on.
That's one of the things that people report cannabis helps with. So a lot of older people, so one of the biggest, fastest growing demographics of cannabis consumers right now is actually older individuals, middle and actually elderly people. And there's a couple areas where they often report getting relief. One of them is chronic pain, which we touched on before. The other one is sleep. A lot of people report that, consuming a little bit of cannabis before bed helps them stay asleep for longer and not have such a fragmented sleep.
Well, that's actually really interesting because we were talking about the fragmentation of sleep.
Right.
And so what Nick is saying, who's a Harvard-educated neuroscientist, is actually it defragments the sleep, or it makes it more continuous.
Right.
So they don't have those disruptions and they don't have those interruptions.
So. Oh, that's fascinating. Yeah. Okay. So seniors experience sleep and insomnia very differently than younger people do. Next, we move on to the question of whether or not cannabis is an appropriate medicine for seniors. We heard from Jordan Tischler. He's a doctor working in Massachusetts. We've heard from him before. Here's what he has to say.
Yeah, absolutely. I mean, if you think about it, it makes a lot of sense, right? And once you get past the whole stigma aspect of things and start to really just think about this as a medication for what ails you, then the group that has the most ailments is the older group, right? So that they have a ton of pain from a whole range of sources and oftentimes have a number of inflammatory disorders that have kicked in, like rheumatoid arthritis, etc. And then also, there's a fair amount of anxiety and depression that is known to be more common in the older folks and typically underdiagnosed and undertreated. So this is definitely the target population, and it's definitely the growing population.
Yeah, I mean, it's again, the irony strikes me that seniors are the population generally least comfortable with cannabis and the ones who can potentially benefit the most by a long shot.
But it also makes sense why they're actually the fastest growing population. Fastest growing population in terms of using cannabis in a clinical use.
What
in a clinical?
Are you talking about demographics, or what sparks that?
No, I'm saying that what we've seen so far is that actually the fastest growing. I mean, but they started at a very low threshold, right? I mean,
right. Okay. Yeah.
But they are the fastest growing.
Yeah, for sure. Yeah, a lot of sources corroborate that. So, if seniors have different sleep needs and cannabis is potentially a good fit for those needs, what are some of the challenges that seniors face in using cannabis on a functional level? For that, we go back to Eloise. We've heard from her before. I want to also point out that she is actually Lucy's caretaker, and fret not, we will be returning to Lucy soon. Okay, here's Eloise.
It's very overwhelming for them. And, often when they meet with me, I'll give them very specific guidance, like, here's the type of product you need to look for. And they'll walk out with completely opposite of what I've recommended. Or they'll get a free sample, like a free cookie that can be anywhere from, 50 to 100 milligrams of THC. And they tend to really like sweet things. And, they don't understand sometimes the consequences of, over medicating.
I don't know about you, but that strikes me as unethical at best. Handing out free cookies that contain cannabis to people who are completely cannabis naive, to anyone, frankly, but especially this population.
Yeah, I would agree. And that actually definitely resonated with me in terms of some of the, I think, reforms that we need to make in terms of how dispensaries work.
Yeah.
Because it's not about like, oh, let's just, let's give out this free sample or this free sample, because they have to get the right medicine.
Well, exactly. It's a question.
It's not like you go into a pharmacy and they're like, you go in for your prescribed Wellbutrin, and they go, let me give you some Zoloft, maybe some, we're going to give you, like, would you like this?
You'll love the pink one.
Yeah.
Yeah, exactly. Well, again, it's a question of perspective. I mean, is this medicine or is it adult use? And we're trying to move from one into the other.
And each has its place. So, but we shouldn't be mixing the two.
Yeah. Here's one more bit from Eloise. I thought this was interesting.
I would say that packaging is a big issue for seniors. They can't read small print. They can't often open some of these things because they may have arthritic hands. They may have neuropathy in their fingertips, so they can't feel it.
Yeah, she brings up, great points. Especially Eloise mentioned not being able to read it.
Yeah.
But I do sometimes, I wonder even if they can read it, because I've gone into dispensaries and you can read it, and from a scientific perspective, it doesn't actually make sense what the packaging says.
It's misleading.
It's mislabeled.
Yeah.
And that's an important thing that I think definitely we have to address.
Well, and this also makes me think, this is such a weird bind we're in, because according to the federal government, this essentially doesn't exist. They're starting to acknowledge and fund research on clinical cannabis, but it is definitely still a gray area. It's state to state. And who regulates food and medicine labels? The federal government.
Well, in the FDA, the FDA is responsible for that. And I know a lot of people at the FDA, and I think they do a great job, and they have got a very challenging job at it. But they're not, their focus isn't cannabis, or it's not really botanicals. And even, when we talk about supplements and vitamins and stuff like that, like the FDA, they don't overregulate that because it's not technically medicine. So there's lots of disclaimers and stuff like that on these different things that they can't.
Well, my point being, I'm not blaming the FDA. I'm just saying it's not even under their purview yet, because it's not regulated on the federal level.
No, it's only under their purview in that if a company makes claims that, if they make sort of claims that they can't, that very interesting area, right? Because we're talking about medicine. And if you talk about it in medicine, then it is under the purview of the FDA.
Right.
So it's a very weird sort of gray area, whereas we almost need to figure out a way for the FDA to regulate it in a different sense. That's my opinion.
Yeah. No, I appreciate that. Okay. Now I think it's time to get back to the star of the show. Of course, Miss Lucy Hanson.
To this day, I do not remember any of that time. Tanya tells me, my other daughter tells me what I said, what I did. I do not remember any of it. And this was only 2 years ago.
Okay. So what changed?
Cannabis.
Yeah. You could have guessed it. Jeremy, you said something interesting about...
No, it's just kind of a little bit ironic, right? Because we kind of think of cannabis as impairing memory, or potentially impairing memory. But in her case, in her situation, actually, she went from not being able to remember anything and having dementia to now she's very lucid and very She remembers everything.
Well, she's back to herself.
She's back to her normal self.
Yeah. Well, let's hear from her.
Now, the difference is that when I go to bed, I know that if I'm not sleeping, that I'll sleep eventually. I am not anxious. I don't have this feeling, oh my goodness, I'm not going to sleep. Because that was always on my mind, the fact that I couldn't sleep, I wouldn't sleep, I had nightmares all the time. Oh, I still have some nightmares, but I mean, it's simply not the same at all. I just don't mind going to bed. I look forward to actually turning off the light at 11 o'clock, you know?
I want to point out that this is a woman who experienced insomnia for, 80 odd years.
And so the insomnia itself actually created anxiety.
Yeah, absolutely. I mean, we talked about that earlier.
So we're talking about the reciprocity between these different comorbidities, right? And so it's like, well, is the anxiety causing the insomnia, or is the insomnia causing the anxiety? It's like very sort of synergistic in an adverse way.
Yeah.
But for her, now it helped her relax, and she no longer had that anxiety about going to sleep, which was pretty profound.
Yeah. I'd also like to point out that it seems incredibly easy for you to use the word reciprocity. I always have to think about it for a good half second before I try to say it.
Well, for the longest time, I used to say reciprocity.
Oh, okay.
Reciprocity.
It sounds great.
It's pretty easy.
Yeah.
You like it?
Very much.
You should use it more. Actually, reciprocity. We should have a little reciprocity here.
Oh, are we doing that?
I think so, right?
All right, this is getting meta. I want to hear from Tanya, Lucy's daughter, on what this experience meant to her.
She honestly, she's a kick in the pants. My mom has such a great sense of humor and such a great attitude. We've gotten all of that back. And the depression for her was just horrible. Although, she still lives with pain, she doesn't obsess about it anymore, and she's able to enjoy life. And I don't know if Mom will hear this podcast, so I don't know. I don't want to spill the beans, but I am hoping that in the spring, when it gets warmer, that she can go back to France. Mom is French, and she had gone one time, and did not go well. That was a couple years ago. But I think, honestly, she's well enough to be able to go back. So I will speak to her about that probably after the first of the year.
So kind of an insanely good ending. Better. I don't want to give people false hope that each experience ends as wonderfully as this one has. But this is a story we really felt that we needed to share. I think Lucy and Tanya are both special people, and we just couldn't be happier that this is where they find themselves. Of course, Lucy has to have the last word. So here's her parting shot.
Find someone, a reputable doctor. You don't have to go to quacks. They're not quacks. They are doctors who do believe that it will be helpful, and so do it. That's it.
Thanks, Jeremy.
Thank you, Steph.